Well, it's noon Central Standard Time, so I think we'll go ahead and get started. Welcome to the Nutrition and Aging Resource Center's webinar, Connecting the Dots, Utilizing Data to Build Strong Partnerships. We are excited to welcome Dr. Karon Phillips. Dr. Phillips is a public health gerontologist working in the Washington, D.C. area as the Policy Development Manager at Trust for America's Health, co-leading the Age-Friendly Public Health Systems Initiative. Dr. Phillips also serves as an adjunct professor for the University of Maryland, Baltimore County, and University of Maryland Global Campus. She is a public health gerontologist, community engagement specialist, storyteller, and educator. Dr. Phillips has been engaged with the field of aging for over 15 years. Most recently, she served as the program manager for N4A, or the National Association of Area Agencies on Aging. In this role, she developed content and resources for Engaged, the National Resource Center for Engaging Older Adults. Prior to her work at N4A, she served as a scientific review officer contractor for the Center for Scientific Review at the National Institutes of Health. In this position, she supported the scientific review of research grant applications made to the NIH. She also has experience leading the implementation of programs and services focused on health promotion, including chronic disease self-management and falls prevention, and developing new partnerships to provide community-based services to older adults. Dr. Phillips has significant experience conducting and coordinating coalition building and programmatic activities to promote healthy aging and health equity. She has extensive training in community-based interventions and the development of community-based partnerships. Along with facilitating the addition of new programs and services, she has developed and led numerous research projects and multi-site needs assessments in several communities that serve older adults. A native of Atlanta, Georgia, Dr. Phillips received her undergraduate degree in English and Women's Studies from Cornell University, a Master of Public Health with a concentration in health policy and management, and a PhD in Aging Studies from the University of South Florida. She is a proud member of Delta Sigma Theta Sorority Incorporated and Batala Washington, an all-female Afro-Brazilian drumming group. During today's session, Dr. Phillips will share information and discuss the importance of collecting evaluation data to inform partners. Before we get started, I want to mention some housekeeping items. First, we will hold questions until the end of Dr. Phillips' presentation. Our team will be monitoring the chat and Q&A throughout the session. Please write any questions you may have here. We will start the Q&A session with the chat questions first. You can also raise your hand using the icon and ask your question orally. At the end of the Q&A session, we encourage everyone to complete the evaluation that is accessible with a QR code or the link that will be placed in the chat. The information you provide will help us during our next webinar. The Nutrition and Aging Resource Center is continuously working to improve the accessibility of events and content. Automated closed captioning will be provided for this webinar. Participants can enable captions by selecting the CC in the toolbar or closed caption in meeting options. This webinar will also be recorded and made available on YouTube. The video, with captions revised for precision, will be shared via the Resource Center's newsletter. If you have any questions about captions or additional accommodation requests, please email nrcna@iowa.gov. Finally, we did not seek prior approval for this event for CPEU credits for dietitians. You can still receive credit under the CPE Activity Type 171 teleseminars and webinars. Please visit the CDR website for further instruction. And with that, I think we'll turn it over to Dr. Phillips. Welcome.
Thank you so much. I appreciate the warm greetings and I think it still might be good morning for some people, good afternoon for others. I think you have to take your slides down so I can share my screen, and then we will get started. So making sure everyone can see my screen, and I will get started. So again, greetings.
That's great.
Oh, thank you. So greetings, everyone. I'm excited to share, and honestly, I will tell some stories, so humor me in those, but I'm excited to just talk about data and how we can use those to build strong partnerships. So I want to share a little bit about Trust for America's Health because a lot of the context I'll be presenting today will come from the work that I'm currently engaged with. And I will pause for a minute just to say I was excited to see, I didn't see everyone. I had to move the chat box away, but I saw a lot of AAA colleagues, and I'm excited to engage with you all. I engage with AAAs a lot, obviously, in my day-to-day, but we also engage with AAAs in my full-time role as well. So excited to see you all here and excited to see some other colleagues. I will make sure to try to touch on all the different entities I saw as best as I can. And if not, please feel free to ask me a question. But so I work for Trust for America's Health. It is an independent, nonpartisan, and public health prevention focused organization. We are critically committed to advancing evidence-based policy and advocacy with a keen focus on equity. I will talk quite a bit about equity today. Improving the health of every community and making disease prevention a national priority. So I am specifically one of the main staff on the Age-Friendly Public Health Systems Initiative. This work is funded through the funding from the John A. Hartford Foundation. We're very grateful for their partnership and their support of our work. And TIFA, and you'll hear me refer to Trust for America's Health as TIFA throughout the presentation. We produce a lot of reports and we produce a lot of guidance, and we focus again on advocacy, but we also produce information that can guide practitioners and policymakers on critical issues. So we more recently released our Ready or Not report, and it focuses on preparedness for diseases, disasters, and bioterrorism. So just FYI, we do have several reports that we produce every year as a whole. So I will present a little bit of a public health lens and give you a little bit, again, my storyteller coming out. Public health, that's one of my backgrounds, or a large lens of my background. And when you start thinking about aging, and if you look very closely, and this is a word cloud, and we ask people, what does public health mean to you? And you see data, obviously, you see drinking water, obesity, vaccines, but aging is right in the little middle, kind of on its own. But I'm here to tell you that not only does aging have a place in public health did such a great job of keeping us healthy. We now are older, and we need to be considerate of the fact that our population is older and then that public health lens needs to continue on and have a life course perspective. So there has been a limited focus on older adults. When we think about it at the local and state level, we have and again, this is a public health lens. This is not speaking by any means to our colleagues that work in the aging sector, but the public health focus has really not been on older adults. The CDC does not have an overall focus on healthy aging. There are specific initiatives within the CDC, but there's not one that focuses on healthy aging. There are specific targeted efforts. So we talk about fall prevention, we talk about vaccines. And again, it's interesting, the pandemic did bring about some opportunities for partnering and working with older adults. And then we have the Administration for Community Living and state and local, our aging partners who do provide those services. But again, public health has not seen themselves in this role or is not involved with it at all. So again, part of this is a conscious thought about an age-friendly ecosystem. Where do we fit in? Where do we see ourselves intersecting with all this to promote best practices in healthy aging and age-friendly efforts? So I represent, again, age-friendly public health, but we have age-friendly age-friendly employers, age-friendly health systems, age-friendly universities, the AARP age-friendly cities and communities. I think I saw someone from the Livable community in the chat that's attending. But again, these are all practices that we need to be mindful of. And the key thing is these are all partnerships. These are all relationships that we have to form. Even within the age-friendly public health system, it is based on departments of health partnering with the aging sector. Within the age-friendly AARP cities and communities, a lot of that is, again, partnerships with different agencies and entities at the community and local level. So I'm going to ground you again in a little bit of our focus on equity, and I'm going to really highlight one of these, our key framework components. So this is our age-friendly public health systems framework, and we focus on how public health, again, can make healthy aging a priority. So we have connecting and convening. Again, that's something that public health does well. Coordinating existing services and support. So what is public health doing that can be supporting to older adults? And then the key thing, obviously, and the reason we're here today, collecting and analyzing and translating relevant data, communication, important health information, complementing existing health programs and services, and then creating and leading policy systems and environmental change. So what is an age-friendly health department? A lot of different components, a lot of different key things, but you'll see right in my fourth bullet, formal collaboration required across all agencies. Again, who are we working with? Who are we partnering with? Who are we connecting with? And making sure that older adults are at the table as well. And then finally, just to give you a map of where age-friendly public health is, we are working to make sure that we're across all of the states. But right now we are focused in these key areas. We have age-friendly states, we have age-friendly champions. Champions are people that complete 6 of our trainings and they're able to designate themselves as an age-friendly public health systems champion. We also have engagement with tribal territories in the state of Washington. And again, this is just to ground you in our movement and a little bit where my framework will come, or my approach will come from in this presentation. But let's get to the real meat of why you all are here and talk about partnerships and why they're crucial. Again, I highlighted for you, my perspective is always, you can't achieve as much work as we have done without collaborating and connecting and convening. So partnerships are critical. We've seen that throughout the pandemic. We've seen that even moving forward. Yesterday was a very significant day. The public health emergency has officially ended. How are we going to continue? A lot of programs have shifted, modified, ended. What does that look like moving forward? How do we continue to support older adults if a lot of the support and resources that we once had that were available and that were flexible are now ending, and we need to figure out how we can continue in this phase. I don't want to call it a new normal, because what is normal, but in this phase that we're in. So I wanted to take you on a little bit of a journey. We're going to go back to the days when I worked in affordable housing. And by the way, I will note that most of my pictures are actual pictures from when I worked in these communities. But we're going to talk about housing for a little bit. So, and for my colleagues here that are focused on nutrition, I'm going to try to make sure I give some nuggets about how we used our data to support nutritional efforts. But this picture actually is from a community room in Richmond. And the older adults were preparing to move into this community. And we were asking them in a focus group type setting about what they were interested in terms of programming and activities they wanted and resources that they needed at that time. So a little bit of housing disparities. I don't think this is going to be too new for many people, but a greater proportion of racial ethnic minorities experience some form of economic, social, or physical problems in accessing housing. And a lot of that is represented in African Americans. Even though they represent 8.7% of the population, they are a significant high percentage of nursing home residents. And then we have older adults living in high poverty neighborhoods. Again, these communities that I will be highlighting are affordable communities and represent older adults that have certain income restrictions. But distribution of older adults living in high poverty neighborhoods, again, a lot of these communities that I worked in were in areas where there was a lack of resources and a lack of support immediately in their surroundings. So we had to be innovative, we had to partner. I'll get into that momentarily, but again, just showing you just the distribution of challenges experienced from older adults living in high poverty neighborhoods. So we know that many older adults want to age in place. I actually have started saying aging in place and aging in community. I say both. I know some people prefer aging in place, some people prefer aging community. It's actually, in my mind, both, because you want to age in your physical place. You want to age in your home that you've had for a while. You want to age in even the building that you lived in a while, but you also want to have a community that will support you being able to age there. I saw someone in the chat from Silver Spring. In Silver Spring, in downtown Silver Spring, we have an older adult housing building. I think it's 55 and up, and it's right next to the library. And it's walking distance to a movie theater, walking distance to the grocery store, walking distance to all kinds of amenities and attractions. That's the kind of community I personally would want to age in, and I want to be a part of because, again, it's accessible and it has resources to support me as I may choose to give up driving when I get older. But 1 in 4 older adults do live alone, and that is more, women are more likely to do that than men. And the ability to live alone is influenced by a lot of different factors. So again, we talk about aging in place. Is your physical place somewhere that you can actually age? Is your community somewhere that you actually will be supported? At TIFA, we are beginning to also consider and examine rural context and what kinds of resources and supports. We know the challenges, but what can we do to support older adults in rural communities? And what kinds of places and resources do they need to support being able to age in place or age in community? So I'm going to take you to Annapolis, Maryland, in a community I worked in well, not that many years ago, but a little while ago, called Wiley H. Bates. It was a community, it actually used to be a high school, and they converted into housing for older adults. So you enter into these communities, and I'm giving a narrative, and you may anecdotally know the status, the health status, but you don't have any documentation. One of the first things and one of the first opportunities that I became aware of with working in affordable housing communities is that we know a lot of these older adults have these challenges, but it's not documented anywhere. And they're independent, so it's not like as if we are in a nursing home and it's in a chart. We don't have this information. But also, how are we going to use this information? How are we going to leverage these questions and this data to work with agencies? Again, if you were working with a healthcare provider or even a health clinic, they're going to say, okay, well, what are some of the things that you're interested in having? And you could generally offer things that you think the older adults may need. But part of this is not just assuming that you know everything about them. Just again, anecdotally we know, but we didn't want to make assumptions. And then it's also, again, data talks. So if you can say, well, we're serving a community where there's 75% nutritional challenges, we're serving a community where falls are happening, and we need to make sure that they are aware of different opportunities. That is a great tool and resource to help leverage new relationships, new partnerships. So we created again, this is just a snapshot of the actual tool that we use. We combined several different tools to create a tool, not only to get to know the community, but also to get some information on it. And we didn't ask specifics that would make them uncomfortable. If they declined to answer, we obviously respected that. But again, having this documentation, having the information on not only what they were interested in from a social perspective, but what their health needs were, was very helpful in helping us develop new and innovative partnerships. So some of the results from this assessment in that community, falls, there was about 25% falls. And again, remember, these are independent living older adults, and these are independent communities, and the staff, we were not medical professionals. We are, many of them were social workers. I was a gerontologist, obviously, with a public health background. So we're not equipped to do anything medical, but we could seek out, work with, and partner with colleagues that could do this. This was also an opportunity for us to work with our local community, our AAAs, our providers in the aging sector that work with falls. So again, this is housing in the aging sector, housing and departments of health, housing and nutrition providers. So falls prevention programming, we increased that, and we saw that as a need to bring in much more regularly. Obviously, we noted that diabetes was over 55% in that community. And in general, because again, they only have so much support with activities of daily living and independent activities of daily living. There was a general need for that. So we specifically use this to target those relationships. So what is the result? What are the resulting collaboration and partnerships? We worked with the Anne Arundel Medical Center. And so we worked with physicians and nurses to have a quarterly Ask a Doc session. Again, a chat. we made it a program. We would bring in just some light refreshments and have the residents come in and ask their doctors questions. They may ask us, and we're not equipped to answer those questions, but a physician and being just provided to answer questions and get general guidance on information was well received. A flu shot clinic. Again, that was an opportunity to partner with different entities to bring the vaccines into the community. Heart Healthy Valentine's Day party. So again, we think of Valentine's Day party, we think of candy and things, but we made sure there was a heart healthy focus. We had a cancer screening program annually. We always have health fairs. I noticed that a lot of the communities I worked in before I became staff, they would do health fairs, which were great. They were great, but it's like, what was the next step? So you got these resources, but what was the connection to helping that person become better equipped, better engaged with their health? So taking that, but taking it a little bit further and bringing those partners back. So it's often those same partners that we asked to do flu clinics and asked to engage in other things. Like we had exercise classes and we would ask them to come as well. We had clinic hours, and the clinic hours were monthly. And again, they were in a closed private area where they could go and get acute care, but also again, just ask them questions. Little story. I gave a presentation several years ago at the American Society on Aging, and we were talking about this idea of partnering. And I shared a model where older adults in Richmond, we actually worked with the Virginia Commonwealth University to bring in a program that they had already developed where they bring in a wellness clinic. That's what they refer to it as. And the clinic consisted of students. They were supervised by appropriate staff and faculty, but the students got exposure working with older adults. And the clinic provided older adults with an opportunity to get that acute diabetes, not diabetes, but blood sugar checks and blood sugar checks on a regular basis, and just ask them general nutrition questions. Because the students were in allied and they were nurses. I don't think we had any medical students or part of the program, but again, it was an opportunity to get some acute care, and that happened once a week. So I mentioned that program, and a woman stood up and said, "Well, we built this brand new clinic in a community that I work in. We gave them all the bells and whistles in terms of equipment when we brought a doctor and a nurse in, and the older adults are not using it." And I asked her a simple question, and I said, "Did you engage the older adults in this process at all?" And she looked at me and said, "No, because this is what they needed." And I said, "You have to consider the context of a few things. One, you brought in actual medical professionals. Many of these older adults have their own providers that they use on a regular basis. So for you to bring in a physician that they don't know, I mean, I mean, like many of us, changing doctors, changing providers on any level. Jokingly, I had to change my lawn guy, and it's giving me a little bit of angst and anxiety. But changing and interacting with a new entity when you have an established relationship is challenging. On top of that, it's a small community where you have people that can see what you're doing. So it's, did you see Miss So-and-so is going to the clinic a lot lately? She could be going for whatever reason that she needs to go. But again, in small closed communities, we are more observant. So I also asked her, I said, "Did you invite them to meet the professionals before they came in?" And she said no. And so I said, again, it's not our home, it's their home. So we need to be mindful of when we bring in these programs, when we bring in these opportunities, we cannot just say that this is what's needed. We also need to make sure it's an open conversation. So, and I'll get to what we do with this data, not just to showing it for providers and partnership opportunities, but also close the loop on some other practices that need to be considered as you're moving forward with this kind of information. But again, two key takeaways from this: keep older adults engaged in the process. That is a big overarching theme that I firmly believe in. Keep them engaged in the process, especially if it's in their building that's going to impact them. So some results that we were able to do. So the programs that we developed engaged the majority of the community. 84% of the residents participated in a produce program that provided them with fresh fruits and vegetables on a weekly or biweekly basis. There was no grocery store immediately nearby. There was not one too far away, but if you don't have a car, um, and if you don't have, and I think there's a bus line. I think there is was. I haven't been out there in a little while, but it's still these are all factors you have to consider versus the produce is brought right into you in your community, and there are a lot of great programs that provide fresh fruit and produce. Key other takeaway from this, make sure you explain to older adults how to prepare them. We had a great dialogue once about Swiss chard. They were like, these are not collard greens. These are, what are we doing with these? So dialogues on how to prepare the food, explaining what it is. Because we have, unfortunately, and this is not in this particular community, but I have seen where older adults would trade their food boxes for, let's just say, items that are in the interior of the grocery store and don't require cooking. So we have to also make sure that we're showing them how they can prepare the food. Residents that participated in Positive Food Options Program, which provide bread and bagels. Again, that's another partnership with a local provider in the Annapolis area. 71% of the residents participate in weekly social and recreational events, and 61% participate in the more of the planning and event meetings. So partnership needs. Again, this is where we also looked at, these are again back in Richmond. These are some of my Richmond seniors. I still call them my older adults, even though I have not directly engaged with them in a while, but they're still mine. Coordinating transportation to events. When we worked in Richmond, one of the key challenges that we immediately observed by moving, we actually moved them from a low income area, in an area that was a food desert, didn't have many resources. And we moved them to an area where the bus line didn't run as directly to stores and some of the things that we're used to. So we knew we had to immediately intervene with efforts to coordinate transportation. So that, and in some events, we were able to work with churches to coordinate transportation to different activities and events. Health fairs that were, again, inside the building. Again, we worked with our partners that provided the wellness clinics. And grief counseling was critical because, again, as many of us are going through different things, grief counseling is a strong and necessary programming. Meal distribution. This actually was a cool program. They had a food truck that would come, and it was actually a food truck that delivered the produce. So it was actually pretty cool. And then continuing to make connections to other partners in the community. As we worked with one, we made sure that we didn't just come to the area and say, well, we're here and you need to come give us things. I'm a firm believer of, you have to reach out into the community first before you start asking. And I'll get into that in a little bit. So took you down my journey in housing, coming to present day, and I'm going to talk a little bit about departments of health and data. And this is going to be more broader. This is going to be more of a formal. We're talking about behavioral risk factor surveillance data from the CDC. We're talking larger data sets, Medicare, and things like that. And so I'm going to talk about how this data has been used and how they were able to leverage partnerships, even partnerships to get the data as well. So as I shared, my day-to-day work involves working with departments of health. The first part of our project that I currently work on involved a pilot in the state of Florida. And in that pilot, we brought the Department of Health and Department of Elder Affairs together, and they never met. So that was a great conversation and a convening where lots of ideas were shared, and things were, many connections were made. So what I've shown here is an example of a profile. This is an older profile. We've actually updated it to have based on our 6 C's framework. This is based on our original 5 C's framework. We had 5 originally, but we added another component to our framework. And we developed these profiles around how each county was working with older adults. So you can see population living below poverty that was 65 and older, medically underserved. But then we included different pieces, different efforts that they were leading in that area around different components. So again, coordinating, they were reviewing their emergency preparedness plan. They were collecting data to use from their state health improvement plan, and they were getting ready to develop elder issues committee. They had an elder issues committee consortium for healthier Miami-Dade. I can say that Miami-Dade has done even more since this initial profile was developed. The other thing about Florida is they have an amazing dashboard that we have. We are aware that there might be a few other states, but not many other states have a profile that is specifically dedicated to older adults. It's an interactive profile that is not static. So the data is updated regularly. So it's an investment that the Department of Health of Florida has made. So again, this is an opportunity, and this is where the Department of Health has the data, and they can share this information with our AAA providers and our Department of Aging colleagues, and share, hey, we noticed that in this county, there's a lot of people having falls, and wanted to see how we can partner with you to work with them on getting fall preventions out in that particular area. Again, not to replace, not to take over, but to work truly in tandem. I just got back from Mississippi last week, and in Mississippi, they're doing some amazing things. They're essentially creating, I think, if you remember back, I showed you that 5-prong or 5-loop ecosystem, and that's essentially what Mississippi is trying to do. They were a sub-grantee. We funded 2 states, Mississippi and Washington State, and they are trying to create their own ecosystem. But they created a healthy data report that they released last week. And this healthy data report was developed in collaboration with UMass Boston. So it was a free opportunity. And if you think about what that means for any of my academics in the audience, you now have opportunity to learn and develop a massive report about data specifically for Mississippi, and Mississippi can use this data to help show partners and show other entities why this is important. So there were lots of indicators, as I mentioned, CMS data, there were community profiles, and then they have interactive web maps, and they have an actual booklet that they are sharing, but they are planning to upload this to a system called Power BI and make it iterative. Some of the next steps they obviously are looking forward to is how they can keep the data constant and keep it fresh, if you will, from year to year, because they don't want it just to be static data reports that are not updated. And then as our other sub-grantee was Washington State, just showing you the 6, can't count, the 6 key areas that they were working with. This is, again, all headed through the Washington State Department of Health, and Mississippi was headed through the Mississippi State Department of Health, and also showing that the tribal engagement, the tribal communities that they were working with through the Northwest Washington Indian Health Board. And they also developed profiles, and they too are planning to take these profiles a step further to help them gain not only additional partnership, but here's a key word that I know many of you may be interested in hearing me say: funding. So the director of healthy aging at Washington State shared with us that they were able to use this information and use this work and the data to help them connect with another project that is funding different efforts related to health in general. And so they were able to make the short list of different initiatives that they're going to get funded related. And again, I think this is the only one specifically related to older adult health. So they were able to, again, not only leverage the work that they're doing, but they had data. They had their county level profiles to show this is what older adults look like in our community. They also want to take their data profiles and turn it into a dashboard, just like Florida. And I simply just highlighted all this, and I gave a presentation at the Gerontological Society of America, and I highlighted, just how innovative it is, and the role of academia. I do wear an academic hat, And I often tell my colleagues, we do have a role in the community. We can't stay away from the community completely. We have the knowledge base and we have the skills to create these amazing data profiles. Again, one of them was done by university. The other one was done with a partnership through our institution called Alterum, and they produced those data reports for Washington. So again, our subgrantees were able to get these amazing profiles that they are able to use to continue their work in developing age-friendly public health and developing new relationships in their states. And again, potential funding opportunities. So I snuck in a little something else. I know there was 3 things I wanted to talk about. I snuck in just a little bit because this is something that came up more recently, and something I always want to make sure I talk about. Um, we've also been able to look at data from a built environment, from a built environment perspective. And the picture you see here, apologize, is a little grainy, but it's called a Moby map. And they typically exist in Sarasota, Florida. And these mats are truly an intergenerational component because they were designed in partnership with understanding, we have older adults that would like to get to the beach. So again, this is more of an observational data report out, but we want the older adults to be able to get to the beach, and they have walkers and they have wheelchairs, and they might have gait issues. And I mean, let's be honest, sand is, even rocky for the rest of us. So how can we help facilitate better access to the beach? Enter in these Moby mats. But guess what the Moby mats did? The Moby mats allowed people to wheel those coolers in because we bring our snacks to the beach. They allow moms with strollers to get the strollers on the beach because who wants to carry 3 kids and the snacks and the sand toys and all the equipment you need to go to the beach. So not only was this something for older adults, but it was for the community. So while we're enhancing our areas, we're also enhancing it that in ways that is supporting all older adults and all the community. So again, there's that life course perspective. And I want to give a little shout out to Greendale, Wisconsin. They were actually presenters on a training we had earlier this year, and they talked about how they use data that they wanted, and it's a small community in Wisconsin, to support the needs of older adults. They conducted an assessment on their needs, and they also conducted what they called a walking audit, and they looked at their trails. And so they applied for an NAARP challenge grant and used that and they used that they based their grant obviously on this green space improvement plan that was going to provide more opportunities for older adults to engage. So we have what they were able to do with that grant. They made updates to their built environment. They added walking maps to their community. They added wayfinders on their trails, and they added benches. Little small effort, but again, it was a data-driven effort. They took the time to figure out what our older adults need. So stepping back very quickly for kind of a recap of what is the impact and implications of all the things that I've just shared. I say that this addresses all isms and bias. I'll specifically call out ageism and bias that we have about older adults and aging. We think we know what older adults need. Now, yes, we know what we need. We know what people need, but taking the time to conduct and prepare assessments lets us know exactly what people need. We can assume, but we don't always specifically know. So I think it addresses bias and isms that we have about not only older adults and aging, but what we think people need. And again, this is also, again, an effort to address and promote equity and provide access to people, encouraging, again, partnerships and collaboration to bring resources and tools into these different communities. Facilitate thoughtful and strategic planning. Again, you can make a plan. Again, remember the woman I shared the story about. You can make a plan, you can decide that's what you need, or that's what people need, but developing database solutions is a better approach. And then let's talk about this briefly, trust building and community relationships. When you not only engage older adults in the process, and again, I should also mention that in our work with departments of health, we encourage them to not only engage with their partners, but to engage with the community. Make sure they're engaging older adults and their caregivers in their plans and their process. But it also, when you're building up trust, you're going to get more of return on your investment. I always say you can't just go into a community and just do things and think that it's just going to work out. You have to spend time in the community. When we were working in Richmond, we spent a lot of time getting to know the immediate community of Richmond. None of us were from there, so we had to get to learn Richmond and build relationships. And in building relationships, it's critical because those relationships can lead to other relationships. So if we have a relationship with a food provider or a nutrition provider, and we not only receive things from them, but support their endeavors. Maybe it may be something as simple as promoting their programming to other partners or attending any event that they have. But they can also, because of that relationship, lead to other connections as well. So I'm very big on not only building that trust and that relationship, but also making sure that you're focusing on your relationships. So some final pieces, so I can, I hope to, I'm happy to answer all questions, any questions. So I call them strong professional practice strategies. That was a long way. I'm stepping away from the term best practices, because when you start working in different settings, it may be a best practice for that setting, but we're not certain it's going to work here. It may be a best practice here, but it may not work there. So I'm not anti best practices, but I'm trying to figure out a phrasing that talks about these are good things to consider. These are good practices that should consider. We're collecting this data, and academics, we are notorious for doing this. We collect this data and we take it and we do not go back. I'm not saying everybody on the call, but that's kind of the trajectory. We take information and we do great things with it, but the people that we got the information from, they don't know what happened with it. I started when I started working in housing, and if I had a presentation, generally it was a poster because I was, a graduate student. I would take the poster back. I give them the poster because otherwise actually have some here in my house, but I'd take the poster back, and if they wanted it, they would take it and they would hang it up. But I also found that older adults like knowing where the information went. I had a resident who he gave me quite a grilling, if you will, about where this information was going. And I said, "Oh, it's going here. I'm going to use this, and this." So I developed this quick little one page. This is what we found out about you all, and we had a little chew and chat coffee situation where we talked about this is where this information is going. This is what we're going to do with it. And this was available to them. This is what I shared that we learned about their community. Um, I also I got this from a conference um, here in DC. It was a national network of public health institutes. I attended that the past 2 days, yesterday and the day before. And one of the presenters talked about the engagement bridge and making sure that you're connecting with people on components that they understand. So there's faith, engaging with faith-based communities, food. I don't think I need to share with you all. People will respond if you're engaging with them about either receiving food or you're providing food. Engaging with them about family, and I'll even add a little dash there and talk about caregiving and caregivers. And I think we know just how critical the role of caregivers are right now. Health and then jobs. And my last couple slides, and then I'm gonna have questions. I was in a session on Wednesday, and I was immediately struck by this model because it's specifically for Indigenous evaluation. But one of the key things, and I shouldn't say but, and one of the key things about this model that struck me is that there is a sense of it's a very cyclical pattern, but it talks a lot about respect, understanding the people of a place, understanding the people are involved in the process, understanding community goals, and understanding the assessment process. The presenter started with evaluators that don't know this model would come in and think that they know what was best for the community. And the audience just said, oh no. And it's like, but that happens. And she said, this model speaks to that. And this model focuses on not only understanding cultural values, but for me, I put my aging lens on this and talked about understanding people of a place, understanding the older adults that you're working with. So again, developing lasting relationships in these communities, you guys spend time engaging with the community. Don't just ask for something first. I've already shared this, but and try to work within existing systems. You know, if you want to partner and you want to collect data, you want to develop a new program, try to work with existing systems, but don't come in with just an ask. As someone asked me once about engaging with faith-based communities, and I said I've attended many church services before I was even invited to have a meeting with the church leadership. So I've attended many church services. But again, that's my approach, and that's how I view engagement and making it last and making it something that is beneficial. And then again, as I already shared, including residents within the process and the older adults in the process. Last slide before I close. This is my late grandmother, and I always like to include older adults that I know for several reasons. One, she passed away in 2021. But you know, my grandmother she was different from me, and she's different from my mom. And we had to think about these different age ranges. When we talk about 65 and older, what are we really saying? We're talking about everybody. Oops, there's a little typo here. I apologize. It should be 85 plus, but we're talking about different pockets of people. So we can't necessarily always say, okay, well, this is going to work for 65 and older. Again, that goes back to my idea of it's not really a best practice for 65 plus, but these are practical considerations. So there's 65 to 74, 75 to 84, and then there's 80, excuse me, again, the typo, but 85 plus. So again, there's my grandmother. There is my principal from kindergarten and first grade who wore heels and drove a Mercedes until she passed away and lived completely independent. So again, think about the age ranges and think about making sure that we're appropriately thinking about different dynamics of older adults in those brackets. And again, respect that process. I can't stress that enough. And I think that's it. I'm in my time because I want to make sure if anybody has any questions, I can answer them. So I will stop sharing my screen and happy to answer any questions. Oh, I don't think we can hear you.
Can you hear me now?
Yeah.
Okay, well, thank you, Dr. Phillips. That was great information on partnerships and evaluation. And that's great. So let's take a look at some questions here. I'll take one that I wrote down from the chat, and it was, is the dietary intake available? And I'm not sure exactly which situation they were talking about, but maybe you can identify that.
Um, intake. I'm thinking you're asking me if we asked them about their dietary intake, or if we asked them. I apologize. I have a 7-month-old puppy who's running wild right now. I'm thinking you're asking me if we asked that question. Yes and no. We did. I mean, we didn't do a full dietary analysis, but that actually is something to consider because, again, as I shared with you all, even when we would give them access to food boxes and we would give them access to different programs that would bring food in, there were still observed challenges that we had to case manage, if you will. I use that term very broadly. But that is actually a good question, and that's actually something to think about. Again, I unfortunately do not work directly in housing right now, but I would take that information and share it with not only my housing colleagues, but they might work with departments of health moving forward. Maybe they can make sure that is something to ask.
Okay. The next one is, can you further discuss the emergency room visit data in the Washington Spokane County profile? How was it collected? How was it portrayed? And what was the benefit of showing this data?
So again, this is all data that was CMS or BRFIS, and that's what they behavior risk factor surveillance. So that part. It was collected from, it was pulled down from those databases. So how I don't know directly how Washington has used it, because that is that their focus has been on dementia, caregiving, tribal, and what else are they focusing on? I mean, again, it varies from community to community. But I can share that from a higher level perspective, knowing what these emergency room rates are can help you figure out, if there's a pocket of high emergency readmissions or even just admissions, something's going on in that community that needs to be further investigated. And that might mean working with the that local hospital to figure out if there is a care transition program that needs to be implemented. I have a history working with care transition interventions. If there is a role for health, Department of Health and or the aging sector to partner more with the hospital. If there is if there is an opportunity for that hospital to become a geriatric ED, that's part of the age-friendly health system effort. And maybe they need to adopt more practices that are supportive of older adults. It can mean a lot of things, but I don't specifically know what Washington is doing. But I can, if you email me, and I can find out more about Washington, what they're specifically planning to do with that. And again, the profiles contain a lot of data, so um, everybody's doing different things based on what they see.
Okay, great. And I think we'll provide the email in the chat so
Okay.
that you guys can contact her. Next question. Do you have any tips on dealing with how fragmented and siloed community resource can be when partnering with those resources?
I mean, that's a real conversation. So um, we try to do two things. One, we try to encourage people to find the champion in these organizations. Who is the person that you can at least work with? We had a conversation with a AAA in Ohio recently, and they were trying to work with the Department of Health. So we were trying to help strategize and help them figure out ways that they can engage with their Department of Health, because they had funding to do further vaccine work. So it's like, well, we need to figure this out because with the funding's here, we have a great opportunity. But we have to figure out, one, if you can figure out a champion, who is the one person there that can say, I can add this to my plate. And again, we understand, and let me phrase, I fully understand that resources and time is not on our side in terms of bandwidth. We all have a lot in the place, especially in our aging sector, AAAs and our departments of health. We're all doing 30 different things. And I should say you all are doing 30 different things, but try to find a champion. Try to present opportunities where there is like low hanging fruit, if you will, opportunity maybe to connect around a program that could be doesn't require any funding and can serve older adults. And it means that maybe your entity can help disseminate it, or you're asking them to just come in as a partner. So again, it might be a trust building exercise. You might just have to spend time working with them on a program that they don't have to spend any money on, because I know that's something we can't always commit to, but maybe getting them to just come and maybe invite somebody to attend, and keep inviting them. It may take some time, and then conversely attend something that they're say that, hey, I would love to learn more about what you're doing, and offer that. Again, we've learned that it just takes convening and finding the right person and finding the right time. Again, with this shift that we're in, um, hopefully we can still ride this momentum of, we saw a lot of innovative partnerships, and hopefully we can continue to ride this momentum of, not, well, I'm gonna call it, in the public health emergency partnering.
Okay, perfect. We have about 5 minutes left, and there's one more question here. Thanks, Dr. Phillips. Do you have any statistics on who used the data to measure impact of data? Any statistics on who used the data to measure impact of data?
That's a tricky question. I don't. That's something that's like the evaluation of the evaluation. That's we see it from a we it's more of an observed data thing. We know that we see it through movement of uh, programming. I mean, if you want to put a metric on it, maybe programs that developed and partners and new partners that developed. I mean, I think that would be a good metric of how those how that moved forward. But I don't have that's a tough. I mean, maybe who there's I saw some PhD students in the chat. I see a project, even a master's student in the chat. I see a project because that is something that we know anecdotally, but we don't know it, from the weeds. We're just excited that someone took the data and it's like, oh, I saw that profile, so we want to work with you on this, this, and this. And we're like, okay, great. Well, not we, but I say we because I did wear a hat where I worked in direct services and now I don't, but we are I dabble back and forth, but it yeah, that sounds like a project for somebody. I'll keep that in mind though. Thanks. That's a good question.
We always need projects, right?
I
So
mean,
we have another question that just came in. Thank you, Dr. Phillips. Where are these types of studies published? I am trying to see the best mediums to see these state level studies and share the results of ours.
so so this so the data I think you're asking about the data profiles. Those are available through the departments of health. Florida has them. Mississippi has them. Washington State has them. Happy to connect you with the people that developed them. And then I know Massachusetts has something like some kind of we call it system. I think it's beyond the profiles, but it might be closer to Florida's data system. Um, and then I think the further question is, and then UMass Boston would be the place to look and see because they've done other profiles for other states to see what they've done beyond developing these profiles for the states. They want to do more of them, but they would be a good place to start. Why am I Elizabeth Dugan, Dr. Dugan at UMass? I think they've done some report outs on the data profiles in terms of like how they've been developed and maybe utilized. But that's where that came from, and they're a great camp, and they know all the nuances of putting these databases and these profiles together. So yes, go to UMass first.
Okay, perfect. Well, thank you again. This has been great. If it's okay, I'm going to go ahead and share my screen.
Absolutely.
Okay. You can hear me, right?
Mhm.
Okay. Let's see. So this is our webinar evaluation. Let's see. We would really appreciate it if you could take a few minutes to complete the webinar evaluation and let us learn a little bit more about how we did and things you'd like to see. And then lastly, just thank you so much for joining us today. The webinar was recorded and it will be posted at a later date on the Nutrition and Aging Resource Center's YouTube page. We will share that when it's available via our newsletter. So again, thank you, Dr. Phillips. We really appreciate your time and preparation. So it was a great first webinar to kick off.
My pleasure. It was a lot of fun. Thank you, everybody, for indulging me.
Yes. All right. I think our hour is up. So perfect timing. Okay. Thank you.